What is up, wing women? Welcome back to part 3 of 5 of our chronic disease deep dive series. Tonight, we're going to be talking about inflammation. It's going to be the same format as part 1 and part 2. We're going to go over why this is important, the markers that you need to look at, what the targets are for those markers, and what to do about it if they're off. Plus, there's going to be a little bonus at the end on how genetics play a role here. So stick around to the end and you are probably going to learn something that you did not know before. I'm going to share my screen here so you guys can see what I'm talking about and share screen. And then we're going to dismiss this little AI companion guy, make this big. Boom. Inflammation deep dive. This is where we're at. We're going beyond the basics. I'm Stevie Sperlin, precision medicine trained physician assistant and health and fitness coach. My goal is to make you guys the healthiest, happiest versions of yourself so you can build a body that lasts into your 80s and 90s. So let's dig into inflammation and how this plays into that. And we're going to start here at the beginning. I know that inflammation gets a bad rap on the internet, but it's not the enemy. Inflammation is actually how your body heals. So take spraining your ankle, for example. Once that process happens, your joint is going to swell, it's going to get warm because your body is sending these inflammatory signals to the injured tissue to start the repair. And also, a different example is when you catch a virus, your immune system is going to mount this inflammatory response to kill the virus, to kill the intruder. So without inflammation, you actually wouldn't be able to survive being in a body. So the problem here, right, isn't inflammation itself. The problem is when inflammation signals are not turning off when they're supposed to. So when your body keeps that repair signal high and firing for years and years after the injury or the illness is gone, your body is essentially attacking itself. This is called chronic low-grade inflammation. It's not usually a diagnosis that your doctor is like giving you on your MyChart, right? It's actually just like a state of being. And we can actually measure this through these blood markers. We just usually don't, which is kind of crazy because I have this data from the CDC here, and it shows that roughly 35% of US adults have elevated hsCRP, which is one of the gold standard markers for chronic inflammation. We're going to dig into this in the next couple of slides. So chronic inflammation also is an upstream driver of pretty much every chronic disease on this list that you see right here. Kind of like how we talked about metabolic disease last week. They kind of go hand in hand. And as you can see here, these conditions are driven or amplified by inflammation, and they include cardiovascular disease, type 2 diabetes, Alzheimer's, and other kinds of cognitive decline or dementias, autoimmune disease, multiple types of cancers, depression, anxiety, and frailty or sarcopenia, which is muscle loss. Okay, that's a lot, right? There's a study called the Interheart study published in 2004, and it showed that about 90% of heart attack risk comes from modifiable factors, and chronic inflammation ran through almost all of those modifiable factors. So tonight, we are talking about not just getting rid of inflammation, we're talking about how we can help the body turn the dial back down when it gets kind of stuck on high. Okay, that's the important piece here. Okay, so the 7 markers that can show you if you have chronic inflammation. So the very first one, hsCRP, you're like, oh my gosh, this has been a lab you tell me to get every single week, Stevie. Yeah, this one's come to find out pretty damn important. So hsCRP stands for high sensitivity C-reactive protein, and it is the gold standard for measuring chronic low-grade inflammation in your body. Now, this is different than a regular CRP, and we're going to talk about that on the next slide specifically, so hold on tight. The next one is ferritin, and this is kind of a sneaky one because this is how we measure your iron stores, but it can also rise with inflammation. And the reason is because inflammation essentially tells your body to lock iron away, to like sequester it and hold on to it. When that happens, your ferritin can spike. That's why women with chronic inflammation can look fine on ferritin, but actually be iron deficient. So we can't look at this marker in isolation, but this, along with some others that we'll talk about here in just a second, can pinpoint, oh, hey, maybe this is what's going on as opposed to that. So homocysteine is an amino acid that, when it's elevated, signals vascular inflammation. So inflammation in your blood vessels. And it tells us about your methylation status. A lot of you probably have heard of this. It's kind of like a hot topic or a buzzword right now. People are like, oh, I have the MTHFR gene. So methylation status is basically how your body controls which genes do and do not get expressed. And when methylation is impaired, it actually drives methylation, mood issues, and detox bottlenecks in your body. So this is important. We want to keep homocysteine below a certain threshold to make sure that your body is methylating well. Fibrinogen is involved in clotting and inflammation. It's in and of itself its own cardiovascular disease risk marker. Omega-3 index measures the actual percentage of EPA and DHA in your body, the two main omega fatty acids in your red blood cells, like the membranes of your red blood cells. This is what this index is going to measure. It is a dietary inflammation marker. And then, last but not least, NLR is the neutrophil to lymphocyte ratio. Neutrophils and lymphocytes are two types of white blood cells you already get drawn on this thing called a complete blood count, or a CBC. And this is a basic panel that your doctor will run every single year on like your annual exam or anytime you're sick, or basically anytime they're drawing blood, we're just like throwing a CBC on there. So you just need to make sure that it's a CBC with differential, so it'll break it down far enough for you, and we can get those two numbers, absolute neutrophils, absolute lymphocytes. And we're calculating this NLR number by dividing neutrophils by lymphocytes. And that balance is a signal for your immune system. All right. So this is free hidden data just in the labs that your doctor's already ordering for you. And we'll go over, like I said, the ranges that it should be and what that means in 2 slides. So not all of these are going to be on your standard lab panel. You're going to have to ask for them. Really, the only one you can extrapolate from your standard lab panel is probably this neutrophil lymphocyte ratio, the NLR. The rest of these are generally not drawn on typical lab panels, but they are important, especially if you're trying to optimize and catch chronic disease before it is kind of smoldering. So hsCRP versus CRP. This one trips people up all the time. So it's the same protein that's being measured, but it's a different test. Standard CRP is the cheap, less expensive lab. It detects values below 10 milligrams per liter. And that's the range that you're going to see when you have like active infection, an autoimmune flare, or post-surgical inflammation. This is usually what your doctor orders when they're ordering a test for inflammation. Okay, but hsCRP is the high sensitivity assay, and it detects the 0.3 to 10 milligrams per liter range that we want to look for. This is where chronic low-grade inflammation lives. And critically, this is where cardiovascular disease risk lives. Okay, so there's this big study in 2008 called the Jupiter study. They took patients with normal cholesterol but elevated hsCRP, and they put them on a statin. You're like, wait, what? Yes, they put them on a statin because statins in the right person can save lives. And in this study, the statin actually reduced these people's cardiovascular event rate by 44%. This trial was a huge piece of evidence that chronic inflammation drives heart disease independently of cholesterol, especially the study found this, especially in women, which is kind of crazy, right? So you're like, oh, worried about your cholesterol when you should be equally as worried about your hsCRP, your inflammation within your blood vessel. Those are two buckets of cardiovascular disease risk. Okay, so ask for hsCRP is the takeaway on this slide. Next, what are these targets? What should mine be if I do get them drawn, Stevie? So here's your cheat sheet. All right, the number on the right of each marker is what we're trying to shoot for. And the worry number, or hopefully, the in between, we can catch this early, is when we need to really start making some changes. So we're going to just take a quick pass through each one. hsCRP here, we want this to be under 1. This is going to coincide with a low cardiovascular disease risk. Over 3 is high, and in between is kind of moderate. Okay, so these are actually the American Heart Association's cutoffs and criteria of guidelines here. Over 10 is likely an acute infection or some kind of autoimmune flare. Your body is responding to something right now in the flesh, right? We usually want to retest if you're over 10 in 2 to 3 weeks for your chronic baseline. And if it's still elevated, then we need to investigate further as to why this is happening. Okay, ferritin. We're going to spend a little bit of time here just because there's some more nuance. This is the one, again, like I said, needs the most context. So listen up here. Under 30 is iron deficiency. Yes, under 30. And some of you are walking around at like 14 and your provider is like, you're fine because you're not like literally dying. You don't need like a blood transfusion, right? But you're still deficient. You're still definitely feeling that. Okay, I want you to hear me say that if you feel like trash and your ferritin is like 14, you have a valid reason for feeling bad. There's something going on that we need to address, okay? If it's 50 to 70, I'm sorry, 50 to 150, this is our target. This is what we are aiming for. And really, like somewhere in the middle and towards the higher end here is going to be better, all right? But just higher is not always better. So over 150, we don't necessarily want you hanging out there too much because our bodies like are, oh my God, what do we do with all of this iron? And it tries to like put it somewhere and it puts it places we don't necessarily want it, like in your liver, in your brain, in your organs. So we don't necessarily want to be over 150 for too long, okay? But it doesn't automatically mean that you just have iron overload, right? And it doesn't automatically just mean that you have inflammation. We actually need to look at ferritin alongside 2 other things. One is something called TSAT, transferrin saturation. And the other one is hsCRP or some kind of inflammation marker. Okay, so if your TSAT, that transferrin saturation, is over 45% with a high ferritin reading, we're thinking this is iron overload. Your body has too much iron, right? If your transferrin saturation or your TSAT is normal, but your hsCRP is also elevated, we're thinking inflammation is causing your body to sequester that iron and driving ferritin up. And if both transferrin saturation or TSAT and hsCRP are normal, but ferritin is still high, then we're like, okay, we're looking at like fatty liver disease or some other kind of metabolic factor. So a high ferritin without context is just a flag. It's like maybe this is some inflammation going on. It's not necessarily a diagnosis in and of itself, but it can be extremely helpful. So homocysteine, we want this to be under 8. That is optimal. If we're over 12, then we're like seeing more vascular inflammation, more inflammation inside that blood vessel, right? But really, if we're over 8, we want to do something about it because you're increasing your lifetime risk for cognitive decline and also some heart disease as well. This is easily treatable for most people with either methylated B vitamins, that's where I would start, increasing your intake of choline, your dietary intake of choline. It's like eggs, liver, stuff like that. Google high choline foods and you're going to get a huge list, or use ChatGPT, whatever you do these days, just in order for us to save a little bit of time here. And then there's also some pretty good evidence that in some people, creatine might also drive this down. So we want it to be under 8. Fibrinogen, 200 to 300 is target. Over 400 raises your risk for cardiovascular disease. Omega-3 index above 8% is target. Below 4% is high cardiovascular risk. Okay, this one moves with our diet over about 4 months. So adding those fatty fish, high omega-3 food sources is going to help increase this percentage over the course of 3 to 4 months. And then NLR, that neutrophil to lymphocyte ratio, we're going to target 1 to 3. And like I said, you can calculate this yourself from your CBC with differential. It needs to be a CBC with differential, so we're getting those absolute neutrophil and absolute lymphocytes count. We're going to divide it. It's NLR, right? So neutrophils divided by lymphocytes, and that's your NLR. Over 3.5 is a signal that your immune system has shifted towards inflammation and we need to pay attention. There's something going on, right? Whether it be acute or chronic, we don't know, but it's something that we need to pay attention to. All right. And one thing to remember on all of these are your optimal ranges, not necessarily like the ranges that you're going to get from LabCorp or Quest. These are the optimal ones. And this is where we want you for chronic disease prevention. All right. So how do we fix it? Like, what do we do if some of these things are high? If I have some chronic inflammation going on? Well, I like to think about this as rungs of a ladder. And we're always going to start on rung 1, lifestyle. So that's what we're going to talk about on the next slide. And then we're going to start climbing the ladder as those things aren't working. Okay, so rung 2 is going to be nutritional levers. You can really do these lifestyle, rung 1 and rung 2, kind of simultaneously and see if this can help correct issue. And then after that, we're still not seeing that inflammation come down after like a really good 4 to 6 month trial of rung 1 and rung 2. Then we can move to rung 3, which is kind of supplementation. We're going to talk about which supplements might help with this. And then after that, if we do a good 3 to 4 month trial again with all 3 of these rungs after rung 1 and rung 2, so we're just like climbing that ladder slowly, then we're gonna be like, okay, rung 4, case by case. There is a caveat in rung 4 for inflammation, which we'll talk about with NSAIDs and this thing called specialized pro-resolving mediators that can be used for acute inflammation. But if we have this chronic low-grade inflammation, then obviously this is going to be kind of the last step of the ladder that we want to try. So starting off, rung 1, lifestyle levers, movement, sleep, stress, exposure. All of these things can change that chronic low-grade inflammation. It can decrease it, bring it down. So these are the biggest movers, and they are all more or less free, right? Barring a gym membership that might have a sauna or a cold plunge. So sleep. Gosh, every single one of these, Stevie, has sleep. Yes, it's super duper important. And sleep is the single biggest lever to decrease chronic inflammation. Research from UCLA and elsewhere shows that even one night of sleep deprivation can raise CRP measurably by the next day. And chronic short sleep can keep it elevated. So if you only do one thing tonight, it is sleep more. All right, number 2, strength training 3 times a week. A growing body of evidence shows that resistance training lowers systemic inflammation independent of weight loss. Whoa, that's crazy, right? So the muscle itself is producing anti-inflammatory signals when you work it. That's kind of cool. And you don't have to lose weight necessarily to lower CRP. But if we are losing body fat, then that is also going to help twofold, right? And if we have bigger muscles, then our basal metabolic rate is higher, so we are more likely to lose fat and keep it off long term if we incorporate some sort of weightlifting regimen. All right, so yeah, look, you just have to sleep, lift. Those are the 2 biggest levers that we have here. And then the next one is walking or zone 2 cardio. And this is going to improve immune surveillance. So it's going to reduce one of these like main inflammatory signaling molecules that your body produces called TNF alpha. So just walking can help decrease inflammation. Sauna. Now, this is some of the strongest evidence. And it's like the Finns. The Finns do all the sauna studies, right? So there's a Finnish study. It's called KIHD. I don't know if they pronounce it out loud or what, but it was done in 2015. And of course, it followed 2,300 men over 20 years, but nonetheless, 2 to 3 sauna sessions a week for 15 to 20 minutes each reduced cardiovascular mortality by 27%. And 4 to 7 sessions per week reduced it by 50%. That's not a typo. Sauna also lowers hsCRP directly. I presume the mechanism is the heat kind of vasodilates or opens up those blood vessels. All right, so cold exposure. This is the next one. Don't love it for everyone. And this is where I really want to caveat that this is not true for all women. Okay, if you're already chronically stressed, your cortisol is dysregulated, or you're in your luteal phase of your cycle, cold plunging can actually make inflammation worse, not better. So Dr. Stacy Sims has written about this ad nauseum. So if you use cold, keep it short, 1 to 2 minutes, do it in the morning, skip it for your luteal phase, and we don't necessarily need that cold to be as cold as men. So we actually want it to be a little less cold because our bodies are just way more predisposed to getting very, very stressed out by very, very cold water and cold plunges. So if you are someone who's interested in this, or if you're like, I know this helps me, great. You just need to definitely watch your heart rate variability or your recovery. If you have like a watch or a Garmin or like a Whoop or an Oura Ring or whatever you have, watch your HRV. And if it drops, then you might not be someone that this is going to work for. Your nervous system probably didn't like it. And I don't know, this is good news to me. I am not a person that can tolerate a good cold plunge, and I am not sad about it. So I just don't think about it. I don't incorporate it, but it stresses my body out way too much. But it can, in some women, I would say maybe a smaller handful of women, actually improve inflammation, especially if we do it a little bit shorter and a little bit warmer than all of the protocols studied for men. There's also some genetics that drive this. It's called uncoupling protein 1. This is a just free bonus for you. Depending on what genes or what alleles you have at this uncoupling protein, depends on if cold exposure may or may not benefit you more or less. Most people that I run genetics reports on do not get genetically a benefit from cold exposure. Really, I have not seen very many. It's been like probably less than 5%. All right, stress management. Chronic cortisol drives chronic inflammation, right? Another way we can say that is chronic stress drives chronic inflammation. This is bidirectional. Inflammation also drives stress signaling. It's a negative feedback loop, right? Stress, inflammation, more stress, right? And this is a hard cycle to get out of. Anytime we're in a negative feedback loop, it takes some event, something to push that wheel in the opposite direction. We want to, especially if this is starting to happen. Social connection is the last one on this slide. Loneliness can raise CRP as much as being sedentary or physical inactivity does. That is a measured, tangible marker, not just a feel-good statement. It comes from a large-scale epidemiologic study, right? So this isn't just like a warm and fuzzy or a woo thing. This is like a real science-backed data thing. Find a community of people, get involved, make sure you're hanging out with your friends, make sure you have close relationships with some sort of family, whatever that means to you. It is going to prolong your life pretty much at every level. All right. Nutrition lovers. Cool. So there's 2 halves to this. We are going to do, number 1, what you eat that helps, and then what you might be eating that's actually driving the fire. So first half, this slide, we're going to talk about things to add. Number 1 here, omega-3 rich foods. Okay. So fatty fish, walnuts, flax, chia seeds. The American Heart Association recommends fatty fish 2 to 3 times a week minimum. And then on the other days, you can supplement with 2 grams of EPA DHA fish oil, but we'll get to the supplements on the next slide. Well, 2 slides from now. So polyphenol density, berries, dark leafy greens, extra virgin olive oil, green tea, dark chocolate, man, all the good things, the good fine things in life, right? These are plant compounds that signal your body to dial down inflammatory pathways. Okay, fiber. This also comes up on everything, right? So it's like, wait, all of these lifestyle levers are the same, like more or less, or there's a lot of redundancy between all the chronic disease, right? That's why lifestyle can be some of the most potent risk mitigators for chronic disease. And as you can see, it's just like fiber for everything, lifting for everything, right? Omega-3s for everything. But fiber, super important, 25 to 30 grams a day for women. Your gut bacteria will ferment fiber into short-chain fatty acids, which are anti-inflammatory and feed your gut lining. Okay, that's how that works. So 25 to 35 grams of fiber a day. Stable blood sugar. I know this is like kind of nebulous. I'll give you a couple of pointers, but like freaking high glucose or blood sugar spikes are inflammatory in and of themselves. So all of the things we covered in the metabolic class last week about not spiking your blood sugar matters here too, right? So don't eat lonely carbs. Every time you eat, you have a carb, a fat, and a protein. Try to not eat 2 to 3 hours before bed. All of this stuff, eat within energy balance. So we're not eating a hypercaloric diet or too much food in a single day. All of these things are going to be important for that blood sugar regulation. And protein at every meal. This is also going to help regulate that blood sugar, right? So 30 to 40 grams for women every time they eat, right? So you're not just eating like a plain dry tortilla or a banana by itself. You're going to add some kind of protein to it, 30 to 40 grams, and that's going to support repair, cellular repair, and immune balance and help decrease inflammation. All right. And then this is one with a couple with caveats here, but we'll talk about this at length on the next slide as well. So reduce ultra-processed foods and keep alcohol under 5 drinks per week. Ultra-processed foods drive inflammation through multiple pathways. Industrial seed oils are too much omega-6 in your diet, refined carbs that spike blood sugar, emulsifiers that can potentially disrupt the gut barrier and function. Basically, these foods also can make it very easy for you to eat too much and not feel full. So it would put you out of energy balance, and then your body just starts storing and getting unhappy, right? Another one is alcohol. Right? We said keep it to under 5 drinks per week, but I'm going to say this. Alcohol is directly inflammatory and also disrupts sleep architecture, which compounds the inflammation problem, all right? So like, I don't drink at all anymore because I have some genetic risks for inflammation, and I just decided to cut it out. Really, the healthy amount of alcohol is 0. But if it's something that you're into, it helps you be social, and you enjoy a couple of drinks with friends, I would try, especially if you're worried about inflammation, to keep it to 5 drinks a week or less, all right? Because that's where inflammation starts becoming really evidently measurable. All right, below that, most people can kind of clear the inflammatory load depending. But if you're someone who's paying attention to this lecture, then you're still here at 32 minutes in, you might be someone who should consider potentially cutting it out completely. It was something that really, I feel like I'm way better off for it, but it's a decision that everyone has to make on their own. All right. And then of interest, genetic notes here. How well you tolerate the ultra-processed foods is partly genetic. Fascinating, right? So the FADS1 and FADS2 genes code for enzymes that help you convert plant omega-3s and omega-6s into their long-chain active forms, or EPA, DHA, or AA, arachidonic acid. People with the slow variants at FADS1 and FADS2, they can't efficiently convert these plant precursors to the long-chain forms. So when they eat a lot of seed oils, the inflammatory load actually builds up faster and they can't clear it. So if that's you, you might specifically benefit from less seed oils or less ultra-processed food and supplementing some preformed EPA and DHA fish oil. All right, we'll talk about it a little bit more when we get to the genetics slide, but for now, that's what we're going to say about that. So ultra-processed food is kind of like a thing, right? It's going to make you eat probably too much or make you more likely to eat too much on a regular basis. And it might be more inflammatory to you depending on your genetics or your medical history. Cool. Food triggers, second half, things to investigate. Some of you might have chronic inflammation being driven by foods that you've been eating for years, and your body has actually been reacting to them without obvious symptoms. You just kind of have these non-specific things going on, brain fog, low energy, joint pain that you're like not really sure about. And these are some of the most common offenders or the most commonly inflammatory foods. Gluten, especially if you have Hashimoto's or another autoimmune condition, either in yourself or in a direct family member, meaning your mom or your dad or a sibling. There's research from this guy that has some kind of French name, Alessio Fasano. Okay, that does sound Italian. At Harvard, linking gluten to gut barrier dysfunction in autoimmune disease. So tightly linked to Hashimoto's and thyroid issues. Might be worth trying to cut out if you have one of those things or you suspect you have some chronic low-grade inflammation. All right. Dairy, especially A1 casein for some people. I'm going to raise my hand. I just don't tolerate casein well. I get super bad gas. And casein is just one of kind of the proteins in dairy. So some dairy has higher casein containing parts, and then the other parts kind of whey and casein. Some people can tolerate whey, but not casein. That's me. And some people can't tolerate either. Both can be inflammatory to certain people. So this is the second thing I would maybe try to do an elimination diet of. The next two, eggs and soy. Then nightshades. So those are tomatoes, potatoes, eggplants, peppers, all of the best stuff. So for some people with like joint inflammation or rheumatoid arthritis, I might look at nightshades. And then again, industrial seed oils, corn, soy, canola. These can be directly inflammatory because they're heavily processed and they replace omega-3s with omega-6s and cell membranes. And again, back to the discussion of genetics. And if you already have a higher inflammatory load, this might have a bigger influence on you specifically. All right, so how do you figure out which one is yours? It's called an elimination diet. It removes suspected triggers for 4 to 6 weeks, and when you're doing gluten, it needs to be 3 months because you will mess it up. Promise you, you will mess it up. So gluten needs to be 3 months. And then you watch what happens to your symptoms and your markers, and you might not even notice really until you try to add it back in, because on the tail end of an elimination diet, you need to add the food back in. And then you will find out, for me with gluten, when I added it back in, immediately felt like, oh, I don't know, I'm okay. And then the next day, constipation, eczema. So I know I'm gluten intolerant, and I feel a hell of a lot better now that I do not eat it. All right, so we need to remove the trigger and then reintroduce one at a time. You can do all of them at once. It's crazy. It's called an AIP diet. Or you can just do one at a time, which I recommend. It's a lot less of a heavy lift. All right. So that's the gold standard. And You don't need a food test or any kind of allergy test. If you just do that, you're like, cool. I know I can't eat gluten. I don't need to get tested for that. I just don't do it now because I know I feel better and I know I get symptoms. I'll pay for it if I have it. There are these like IgG food sensitivity panels out there. Some companies that do it are Vibrant, Cyrex. There's some others. Sometimes your medical provider will order them for you. But they're widely used in functional medicine. My VA provider ordered me a bunch of these, but it was looking specifically for allergies, not necessarily sensitivities. But functional medicine, like I said, uses these a lot. But they're really not supported by mainstream medicine, and the evidence is mixed. Here's my take on it. It can be useful for a starting list for an elimination diet, all right? But really not as a final diagnosis. You might pop high on an IgG, add it back in after elimination, and have no symptoms, right? So it can be a good starting point. And then if we can talk about ultra-processed foods one more time, obviously, ultra-processed foods are worse than whole foods, but the size of that effect is smaller than the internet might be telling you for most people. All right. The bigger drivers of inflammation are usually sleep, blood sugar instability, and personal food sensitivities. So those are the big three right there, not necessarily always processed food. So cutting all ultra-processed food without addressing the actual driver will yield limited return. Okay. Alcohol, though, is a big one, and I'm not going to press this point. We've already talked about it. Direct inflammatory hit disrupts sleep architecture and compounds inflammation. Okay, so really, I would add that to as a fourth to the big drivers here, biggest drivers here. Okay, supplements. These are the supplements with real evidence for chronic inflammation. Okay, and the doses I'm giving you are clinical, not necessarily the bottle minimum. Omega-3 EPA DHA fish oil, we want 2 to 4 grams a day. This is a foundation. It lowers hsCRP, improves omega-3 index. The Reduce It trial in 2019 showed that high-dose EPA reduced cardiovascular events by 25% in people, especially with people with elevated triglycerides. Curcumin with piperine. All right, 500 to 1,000 milligrams a day. Piperine is a black pepper extract that improves bioavailability dramatically. It's going to help you absorb that curcumin. Without it, curcumin barely absorbs. Okay, so in 2017, a meta-analysis found that curcumin compared to NSAIDs like ibuprofen for joint inflammation and osteoarthritis trials were comparable. That's crazy, right? So curcumin, but make sure it has that black pepper component, extract component in it, or you're doing it separately. So vitamin D, dose based on what your labs say. Most people do not need, okay, most people can just take vitamin D like 1,000 to 2,000 IUs daily and be fine, but we really need this to be a lab-based dose. So like, are you deficient? What is your vitamin D level? And then we'll treat from there. So between 2,000 and 5,000 IUs daily, international units daily, depending on what your labs say. So I would ask for a vitamin D level, and I probably should have actually added that in the lab section here because vitamin D deficiency drives chronic inflammation through multiple pathways. So test, don't guess, and then dose based on your levels. Magnesium, 300 to 400 milligrams. Improves sleep, which lowers CRP. It's a twofer. Magnesium is super safe, super well tolerated by almost everyone. Quercetin, 500 milligrams, stabilizes mast cells. This is useful for inflammation, especially if you have any kind of like allergic or histamine component to that inflammation. All right. Also of interest, quercetin can be really good if you have like cystic acne or just like troublesome acne. Probiotics. So if your inflammation has a gut story, has a backing in because your like gut microbiome is messed up, multi-strain, 10 to 50 billion colony forming units. Not everybody needs this, and not everybody needs this forever. The best way to do this really is kind of to do a gut health test, see what you have in there and see what probiotic is the best for your body. But if you can't do that, if you don't have the money, the finances, the bandwidth to do it, then like something like Seed is going to be a good company for you. That's going to cover most of your bases. But like I said, not everyone needs this, and you don't need to necessarily be on it forever. Okay. If your gut symptoms are really loud, then your inflammation could be coming from there, and it might be worth a 12 to 24 week trial. All right. This is the last one. We're going to talk about specialized pro-resolving mediators separately, because this is a useful tool that most people just like do not know about. So NSAIDs like ibuprofen, Aleve, naproxen, those kind of things, they block inflammation, but specialized pro-resolving mediators actually help your body actively resolve that inflammation. So they are like two very different mechanisms. And one is a supplement without all of the GI risk and side effects, and the other is, a medication, it's over the counter, but can cause some significant problems, especially if taken long term. So specialized pro-resolving mediators, or SPMs, were discovered by this guy named Charles. Go figure. So Charles Sheeran's lab at Harvard in the early 2000s, and they are this bioactive lipid molecule made from omega-3 fatty acids, actually. The major classes are resolvins, protectins, and lipoxins, and you don't need to know any of that. It's super boring. But here's the paradigm shift. Chronic inflammation isn't just too much inflammation. It's often a failure to resolve that inflammation that started from an inflammatory cycle and just like never finished cycling. So SPMs are the molecule that tells your immune system, hey, we're done, stand down. We can back off, like we can take off our body armor and like relax, right? So at ease, soldiers. So how to actually use these. And you can kind of treat them like an NSAID, and you don't necessarily have to take it daily like a multivitamin. I wouldn't really recommend that. So if you're trying to do it for acute resolution, so for like something like post-injury, like that ankle sprain we talked about, post-illness, recovering from some sort of like training or high inflammatory load, surgical recovery. I'd be careful with that because these can increase some bleeding risk. So I'd talk to your doctor if it was like post-op. But if you're trying to use this for like acute inflammatory resolution, I would do 4 to 8 soft gels a day for 5 to 7 days and try to break that inflammation cycle. Okay. And then subacute, when you're kind of stuck in a little inflammatory cycle for a little bit longer than you think. Maybe this is like lingering tendinopathy, post-COVID inflammation, chronic joint pain that's kind of not resolving. Then we want to do like 2 soft gels twice a day for 2 to 3 weeks. And then maintenance, only if you really need it. So be like someone who is in a longer autoimmune flare between treatments, recurring inflammatory events, hard training cycles, or like, triathletes, then we might do like 1 to 2 little gel caps daily for 5 days on and 2 days off. You are always going to stack these with daily omega-3s. These are not a replacement for fish oil. They're more downstream, and they'll actually be more potent when you're taking them alongside of your fish oil. That fish oil can be daily, and then you can just add these in as needed based on what you're trying to solve here, okay? The cost reality of these things is like, hey, these are pretty expensive. They can be 60 to $100 per bottle. Maybe using these isn't sustainable for most people. I bought a bottle of these like 2 years ago, and I really just like use them as like acute or subacute resolution managers. So I still have it. So it really has like been a good bang for the buck in my opinion, okay? This is not appropriate to use for acute bacterial infections, pregnancy, lactation. If you're on anticoagulation therapy, potentially post-operatively, again, ask your doctor for that specific indication. But anything that's going to like already cause a bleeding risk on top of this and on top of the fish oil, please ask your doctor before you do it. All right. Medication lovers, this is our last level, rung 4 of the ladder. We're going to do a quick run through. Standard of care can be a real tool, right? So don't be afraid to leverage these things when appropriate. I'm not going to get too far into each of these, but we'll touch on them briefly. So NSAIDs, ibuprofen, naproxen, we can use this for short-term symptom relief, okay? We don't live on these. Again, 14 days of NSAIDs at the appropriate dose on the bottle can break an inflammation cycle. We don't need to take it beyond that. A lot of people do. I do not recommend that, okay? So chronic NSAID use carries cardiovascular and GI risk, so risk for bleeding and ulcers. Low-dose aspirin for cardiovascular protection in selected patients. Talk to your doctor about that. Statins, they have a bonus anti-inflammatory effect beyond just cholesterol lowering, and that's what that Jupiter trial finding mentions earlier that we talked about. Metformin can lower inflammation while it lowers blood sugar. This is also a longevity signaler, and there's a trial called the TAME that's testing whether metformin extends health span. The data kind of coming out for that is like, yes, if you have type 2 diabetes, it extends health span, but if you don't, it kind of doesn't. So like metformin in otherwise healthy people doesn't necessarily make that much sense based on what's coming out of the TAME trial at this time. But if you have type 2 diabetes, metformin is a really good option. So GLP-1 agonists, that's like tirzepatide, semaglutide. These can have anti-inflammatory effects beyond just weight loss, right? We know that these are doing more than just making you not hungry and lose a bunch of weight. They're also working on other like sites with other mechanisms. And we're learning that these can actually have a protective feature for cardiovascular systems and your kidneys as well. So DMARDs and biologics. This is like rheumatology territory. This is like autoimmunity territory. So if like your inflammation is autoimmune driven, this is right where your treatment starts to live, right here. And this always should be managed by someone who freaking knows what they're doing. Okay. If you have a suspicion that the person doesn't, then advocate for yourself and get a new person, right? We can always do that in this system. And then steroids, acute use only, side effects can stack with chronic use. Sometimes if I get a little bit of eczema, I have to use a little topical steroid. Sometimes we have to use oral steroids for acute flares for autoimmunity. But we don't want to be on these chronically because they can cause other problems. So some autoimmune presentations respond well to lifestyle alone. So rungs, right, 1 through 3. Celiac is one of them. Eliminate gluten. Hashimoto's can respond to some of these lifestyle stuffs, right? Like gluten with Hashimoto's as well. Some early stage things. But for established like rheumatoid arthritis, lupus, multiple sclerosis, Hashimoto's that's like further into its course, you're going to need some kind of thyroid replacement medication, okay? We're probably not lifestyling our way out of some of these things, and you do need medical management. So please embrace it with open arms. This is one thing that is really, really awesome about the medical system that we live in, is that we can manage this stuff from a kind of direction that we didn't used to be able to. So don't be afraid of it. If you need it, it can change your life. I promise you, if it's done correctly. Again, find someone who you trust, who you know knows their shit, and like hire that doctor. And if you feel like the one that you're seeing right now is not it, then find one that is, because there are people out there who want to help you and know how in the most appropriate way. Okay. So genetics, this is your genetics chat. So wow, my notes on this are really sparse. So here we go. If you've basically slept, eaten omega-3 rich foods, you're lifting 3 times a week, you've managed your stress, everything is hunky-dory, perfect, you've like pinned it all down, you've given it all real consistency for months and months and months, and the inflammation marker is still like freaking won't move, my bet is this is going to happen to almost nobody, because all of the inputs here from these genes are actually modifiable in some way, to some extent, by these lifestyle inputs. So my bet is this wouldn't happen for most people, but we can see by your genes kind of where to start. Some of these are MTHFR. We talked about this. You guys know about this. Methylation efficacy and homocysteine clearance. So if you have MTHFR, then your methylation is inefficient. And for these people, we are actually going to do more folate, more B vitamins to help that process along. COMT. This is going to be a stress response. This is kind of like a warrior, WORRIER, warrior, WARRIER, or somewhere in between. So like people who are like the warrior, WORRIER subtype of COMT here have an increased stress response, and it can have increased inflammatory load. These people need to be really careful about like caffeine, anything that's like really increasing their stress. Roller coasters, like kind of this high adrenaline stuff, you might need to curb that a little bit if you're one of these people. All right. So IL-6 promoter polymorphisms. Baseline inflammatory response is elevated, but like I said, this lifestyle stuff should also be inputs that will help downregulate that and bring it down. Same with TNF alpha polymorphisms. Okay. You have a bigger tendency towards chronic inflammation, and you're going to need more of these lifestyle numbers. ApoE4. This is what I have. I have 2 copies of this. 1 copy. 1 in 4 people have 1 copy of this. Mostly women, which is crazy. It increases our risk for Alzheimer's up to 50% if you just have 1 copy, and up to 10 times if you have 2. This can increase neuroinflammation and, like I said, Alzheimer's risk. So that's why I really just like do it all. And it's like super important to me. So GST family, this controls your detoxification pathway and your oxidative stress handling. Again, sauna, oxidative stress handling with like omega-3s, all of this stuff is really going to help these people. And then those polyphenols are going to be important in some of these GST people. All right, HLA polymorphisms, these are little genes we can see in people who are susceptible to autoimmunity. So if you have autoimmunity in yourself or in your family, we can see these in your genetics. FADS1 and FADS2, we've talked about this, right? These code for the enzyme that converts the plant omega-3s and omega-6s into those long chain forms. Okay, so we're not going to press the point here, but you might be, if you have these lower converting genotypes, more sensitivity to seed oils, to a high omega-6 or a high ultra processed food seed oil diet. And we can run these, like we do this all the time in my program. It's an option to see, hey, like what is my inflammation risk personally, and what can we do about it based on my own genes, which is kind of freaking cool. All right, we did it. We got through all of it in less than an hour. I'm super proud of us, mostly me. I'm super proud of you if you've made it this far. Thank you so much. I hope you learned something. I hope there's something that you can take from this that's going to help you in your life, in your health journey. And then like some homework, we have 2 more of these. I haven't decided what next week is going to be yet, but I'll make an announcement for sure. But homework before the next class is going to be to pull your most recent labs from your patient portal and see if you have an hsCRP on there. You probably don't. Okay. So if you don't, then maybe at your next physical, your next annual exam, you ask for one. Okay. And you can write down 3 questions for your provider. The key one being, this can be one of the 3 questions. Can we add hsCRP to my panel? Right? Plus maybe another high yield would be a homocysteine and a ferritin. I think those 3 can be super duper valuable, especially right off the bat. If you, and most, I feel like most insurance probably covers those 3. If not, and you're not sure, when you go to the lab to get them drawn, ask them, hey, how much is my lab bill going to be? They have to tell you. Right? There's a Transparency Act. So they have to tell you. And if one is like, oh, whoa, that's like way too much for some reason, I don't see why most insurances wouldn't cover those three. But if for some reason one's high, you can just eliminate it, right? And we can be kind of prudent about this situation. All right. So the next thing is track your sleep. So 3 things. See if you have an hsCRP. Write down 3 questions for your next provider visit and track your sleep for 7 days just for data. This is going to tell you a lot, right? Especially if you have like a watch or something that tells you your sleep quality. We want to look at trends over time and see what that looks like because sleep is super important. Okay. And then pick one inflammatory habit and swap it for something neutral this week, like late night eating, evening alcohol in general, ultra processed snacks, if you feel like that has a bearing on you, or if you know you just eat way too much of that kind of stuff, just pick one thing, okay? And I want you to do that for the next 7 days as well. Cool. So group discussion, if you're my client in EverFit, I want you to do this. If you're not my client and you're seeing this on YouTube, then I want you to just drop it in the comment section. And if this like helped you, hey, like the video so I can like see if this is helpful for you guys and if I can make more stuff like this if you want. But drop in the comments as well. What surprised you the most about our discussion today and why? And I will respond to every single person personally. And thank you so much for making it this far. We're going to end before the 60-minute mark. I appreciate you and have the best night. Bye.